The broadcast is now starting. All attendees are in listen-only mode.
Hello everyone. Welcome to this installment of the Practice Perfection Web-Based Education Series. This is Danny Bobrow, President of AIM Dental Marketing, and I'm thrilled to be hosting a true pioneer in the field of caries detection and research. But before we get to the reason we're all here, let me share that Practice Perfection webcasts run for around 90 minutes. While attendees are in listen-only mode, I invite you at any time to submit your questions or comments using the question button on your screen. We will allow time following the presentation to get to your questions. If we do not manage to do that during the webcast, our presenter has graciously agreed to answer them shortly following his talk. As an attendee of today's presentation, you will be offered the opportunity to receive 2 full hours of CE credit. Shortly following the webcast, you will be emailed a brief survey. You have 30 days to complete and return the survey to us. You will then receive your CE certificate. Today's presentation is entitled Caries Detection, Earlier is Better, and will be delivered by Dr. Stephen Abrams. Dr. Abrams is president and co-founder of Quantum Dental Technologies, which has developed the Canary system for crystal structure diagnostics. Dr. Abrams is a general practitioner with over 33 years of clinical experience. Upon graduation from the University of Toronto Faculty of Dentistry in 1980, he established a group practice in Toronto. In 1999, he began working on a non-invasive laser-based device for the detection and monitoring of caries. In 2006, he founded Quantum Dental Technologies to finish development of the Canary system. This system, based upon the PTR-LUM technology, is currently available in both the U.S. and Canada. Dr. Abrams is senior member of the European Organization for Caries Research, ORCA, and the International Association for Dental Research. He has published over 100 articles in various international publications on topics ranging from early caries detection, prevention, and removal dentures to restorative dentistry and dental program design. Dr. Abrams has honorary fellowships in a number of dental societies, including the Pierre Fauchard Academy, Academy of Dentistry International, American College of Dentists, and the International College of Dentists. He has, for the past 15 years, chaired the Ontario Dental Association's Dental Benefits Committee, where he has known the joy of negotiating with the provincial government and local municipalities across Ontario on various government-sponsored dental programs. While leading this committee, he has addressed head-on issues of access to dental care, design of dental programs, and the value of preventive dentistry. In 2002, Dr. Abrams was awarded the Barnabas Day Award from the Ontario Dental Association for 20 years of distinguished service to the profession. I first became aware of this exciting technology thanks to the American Academy for Oral Systemic Health, and had the pleasure of becoming better acquainted with Stephen, Bill, Colleen, Jennifer, and the rest of the QDT team at this year's Chicago Dental Society Midwinter meeting. It is with that that I introduce to you and welcome to Practice Perfection, Dr. Stephen Abrams. Hello, Stephen.
Danny, thank you very much, and thank you for the wonderful welcome. Good evening, everybody, and thank you again for taking time out of a workday evening in order to spend time talking about one of my favorite topics, which is caries, both caries detection as well as the treatment and management of this disease. So as Danny mentioned, the disclaimer is that I'm president and co-founder of Quantum Dental Technologies, the Canary system, and so that one could say I bring a bias to the table, but it's this that really got me involved in understanding caries. And I'll share with you a very short story so you understand how I got involved with this. It's about 14 years ago, around this time, that I'd had an absolutely miserable week in private practice. I'd seen 3 patients with Pitt and Fisher caries. 2 I'd opened into and there was nothing there, and 1 actually I just looked at the radiograph now a couple of days ago, and the caries was huge. And I looked at myself and I said, my God, what's wrong with you? Why can you not detect caries? And it happened to be lying in my chair a patient in our clinical practice who was a physicist. And taking care of him, I began to explain this, and he says, I have a solution. I've got really neat technology that could image defects in crystal structure of silicone wafers, metals in cars, and steel. He said, this would be great for you. And he told me two of the biggest lies I've ever been told. He said, come work with me. It won't take any of your time and won't cost any money. And thus, I started on this journey of understanding what caries was and then understanding how one can create a device in order to deal with tooth decay. So what is caries? Well, part of my background when I talk to government is caries isn't fillings. Caries is a disease. And I really feel that that's one of the key messages that I want to emphasize this evening. Because if we begin to tell our patients that caries is a disease, then we as doctors of the oral cavity or dentists can then begin to look at this disease and how we detect and manage it, up to and including placement of a restoration. So, back in 2001, the National Institute of Health had a consensus conference. And this is many years ago. And so why is this significant? Because this became the real turn in the path in terms of management of caries. They brought together a lot of the people worldwide who were looking at dealing with caries, including members of the dental supply industry and the third-party payers, and sat them down and said, let's define it. And here's the definition they came up with. Dental caries is an infectious communicable disease resulting in the destruction of tooth structure by acid-forming bacteria found in dental plaque and intraoral biofilm in the presence of sugar. Now, that's really interesting because as a practitioner of, at that point in time, I'd been in practice since 1980, I thought that dental caries destroyed teeth. It was involving bacteria, dental plaque, and sugar. There's no idea about communicable. There is no idea about biofilm. None of these things were present. And these new concepts are really what begin to shape this disease. They went on to say that the paradigm shift is, sure, you can place a bunch of restorations and all that stuff, but you're not treating the disease. You're not treating the bacteria. You're not treating the biofilm. You're not treating the communicable nature of this disease. And so that the bacteria remain on the plaque. They're capable of creating new areas of decay. So what do? Well, we used to put in fillings, but that doesn't treat the disease. And so what I began to look at is how do we go about treating this disease? And when I talk to patients, I try and simplify things by saying that you really need three things to deal with this disease. The three elements are the tooth, you've got the diet, which is sugars and carbs, and you have the plaque. And when you put these three elements together, you create caries. And so when you begin to deal or manage caries, you then begin to look at how do you manage the plaque, how do you manage the diets and carbs exposure, and what do you do with that tooth surface, which is the ultimate, recipient of what goes on. And if you can then begin to look at these three elements, you can then begin to manage the disease. Now, this is an interesting kind of graph because when we were in dental school, we started in this whole section up here, enamel lesions, dental lesions, and pulpal lesions. White spots, demin, remin, colonization, adhesion were not really the things that we focused on. And I go back to a dear colleague of mine, Nigel Pitts, who described caries as an iceberg, the classic, as he called it, Dundee iceberg. And we as dentists, we would treat everything above the waterline. But that was this part of the disease, the part that was in this upper part here. Below the waterline, we couldn't treat. We didn't know how to treat. We didn't understand what to treat. And since then, since 2000, 2004, things have begun to change that allow us then to treat what's below the waterline or these early lesions. And we can then treat the whole caries process from start to finish. And if we treat it earlier, and treat doesn't mean drill and fill, then we can possibly prevent it becoming an enamel lesion, a dentin lesion, or a pulp lesion. So let's take a look at what does this really look like. And I'm going to show you some teeth from an extracted tooth study that we did a couple of years ago. So here's a typical smooth surface molar, the smooth surface of a molar tooth that we looked at, and what's going on beneath the surface. Well, there's a polarized light microscopy cross-section of this area of the tooth, and you can see you've got a nice firm surface, and it's a healthy spot. There's the tooth surface. And then if we look at some of the diagnostics that are out there, The canary number we'll talk about is 10, diagonal dent is 0, and there's no lesion there. And both of those canary numbers and diagonal dent are telling you that this is a healthy, intact lesion. Let's take a look at another one. So here's a white spot. Now everybody says, oh, there's a white spot. It could be fluorosis, it could be this. What we're looking at is we're using our eyes to define a surface defect or surface change. Well, what's going on beneath the surface? Well, there's the polarized light microscopy of that particular white spot. So you can see the tooth surface up here. Well, here we are. And there's the demineralized lesion. It's 548 microns or half a millimeter in depth, and you have a hard surface. And that's a white spot. So that's really the beginnings of caries. So we look at, in our study, we looked at the canary number and diagonal dent. Diagonal dent had trouble with the white spot. The canary number was at 55, and we'll talk about canaries later. But it tells you that here you're looking at a disease where you've begun the destruction of this tooth here, and there are ways of looking at it, but not by using your eyes. So let's take a look at this. Was shared, so a good colleague of mine in Ottawa, a pediatric dentist, who shared this slide with me, and he said, so where's the disease? And obviously, we always say, well, there's the disease. That's the hole. And Ian McConaughey says to me, no, 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 no. Here's the disease. All these white spots, those are disease. And we as practitioners need to be able to do the classic, as I call it, drill, fill, and bill. But what do we do, and how do we manage, how do we detect, and how do we educate our patients about these white spots, which are also areas of caries? So let's look a little bit further. So white spots, this is TMR, which is a very high-resolution X-ray image of this particular white spot. There's the caries, which is the black area. And here's the hardened surface. And the reason I'm showing you this is that polarized light microscopy and TMR, if you look at the literature, this is what the images look like. And they become good ways of measuring extracted teeth. But it becomes much more challenging if the tooth remains with your patient. So again, the last thing on our extracted tooth study, this is the classic pit and fissure that fooled me many years ago. And we took a look inside of it, and there's the polarized light microscopy of this particular pit and fissure. And here you can see the caries actually extends almost down to the DEJ. And you can see that it's a fairly large image, a fairly large lesion, and it involves a lot more than just that little pit, which is what I found many years ago when I first dove in to treat things. So here's, again, canary and diagonal dent numbers. But what I want to draw your attention to is the lesion depth is 808 microns. So it's a pretty large lesion. It's not just the depth, but the volume that's very large as well, too. So how does caries progress? Well, here's a classical, just polarized light microscopy view of a lesion, a white spot that's halfway into enamel. And what we know is that caries tends to progress along a straight path. It doesn't fan out, but tends to progress along what are called the striae of Retzius, which we now know are actually packed crystals of hydroxyapatite. And I won't get into a lot of the crystal structure pieces on this, but let's look at how this grows. And you can see as it continues to grow, the lesion now has progressed into the dentin, and you can see it at the DEJ. It gets larger, you're halfway through dentin, and you're into pulp. And it's a very classical study that's been done to illustrate how these teeth break down. It's always in a sort of a straight line path following the crystal structure. So how does it go on in terms of what happens in your patient's mouths? Well, obviously, we know that we've got saliva, we've got plaque, here's the tooth surface, and this is the inside of the tooth. But let's take a look very quickly at what the biochemistry is in terms of what happens with caries. So first thing that happens is that patients consume carbs. Sugars diffuse into plaque. Bacterial enzymes break them down. You get polysaccharides. The plaque continues to grow, but also as part of the metabolism of the bacteria, particularly in the beginning, the strep mutans and lactobacillus, they produce acid. And it's the acid that causes the breakdown of the enamel. And the acid diffuses through plaque, but it also begins to break down the enamel of the tooth. And as it diffuses inward, it continues to break it down. What happens as well is as it breaks down the enamel, you get diffusion of calcium and phosphate to the surface on the plaque. And what you lay down on this surface is actually a hardened outer shell. so that your white spot that you're seeing in those early pictures that I showed you actually has a hard outer surface, and demineralization is going on beneath it. Now let me throw something interesting out to you, because we've been always interested at looking at erosion. Erosion works a little bit differently. Erosion still involves acids, but you don't really have plaque in place. And so once that happens, you have acid exposure, and you don't get a chance to lift off and form a hardened surface. It literally lifts away the enamel, except if you have other additives in some of the sports drinks that may cause calcium and phosphates to chelate or form on the surface. But the key message here is this diffusion of acids into the tooth. It's the calcium and phosphate diffusing to the surface and creating this hardened outer surface. And so demineralization and remineralization is a balance between the acid exposure and the remineralization on the surface. And we'll look later on at how you can drive remineralization. But it's a balance, and my dear friend John Featherstone always describes this as a balancing act between demin and remin, and how you can then shift the balance towards remineralization. So demineralization, as we just said, it's dental mineral, it's acid soluble. You add some organic acids produced by your plaque bacteria, and you get demineralization. If fluoride is present in water between the crystals, it inhibits mineral loss. And if it's incorporated into the crystal structure of the tooth and you get fluoride, it makes it less or more resistant to the acid exposure. Now, remineralization is just the reverse. You have calcium in the tooth and in water from the saliva, plus phosphates in the tooth and water from the saliva, you'll get remineralization. So it's this dynamic course of demin and remin. I know these are two very simple illustrations of the actual biochemistry that goes on, but the message here is that what you're looking at doing is a very dynamic process that goes on of demin and remin. So fluoride, again, speeds up remineralization. Now, this is all fairly obvious. There were some early studies done in the 40s and Steffen curves created to take a look at how quickly saliva can recover from an acid exposure. But this is a nice illustration to provide to patients to show them that your pH sits at neutral at 7, you have breakfast, lunch, soda pop, dinner, and there are periods of really acid exposure where you're driving the pH of saliva down to around 4, and then it recovers. Depending upon the buffering capacity of saliva, you can leave the pH at a very low level for a long time, and thus you create a lesion. And so you also have to look at saliva, which isn't one of the things that we'll be talking about tonight, and its buffering capacity and components that may help to drive the demin and remin process in the wrong direction. So caries is a bacterial infection. And what I want to share with you is we know which bacteria it is, but it's transmissible. And what that means is that in high-risk populations, caries can be passed on to the child. And so what I talk to government about, and we'll be talking about this actually on Friday, is the fact that if you want to treat caries in a high-risk population, you don't go after the child, but you go after the playmates, the caregivers, the siblings, because there's an interrelationship between all of them. So what do I mean by that? Well, there are a couple of very interesting studies that have been done over the years. There was a study that was done on a high-risk population of moms that were pregnant in New York and on Medicaid. And what they did was dose them once with fluoride varnish before the children were born. And they found that the onset of early childhood caries, or very aggressive caries, was delayed by about 2 to 3 years in 35% of the population, just by single dosing of fluoride varnish. There's an interesting study that was published in the caries research a number of years ago where they looked at children in a Brazilian nursery school and looked at the genotype of the bacteria, the strep in their mouth, and found they could track it back to one kid. And so what had happened is one child had infected the others. So really, when we talk to patients, we talk about the fact that caries is an infectious disease. This is a study that was just published that last month, and this is work that was done by Featherstone's group and a group also out of Chapel Hill, North Carolina, and they said maternal salivary bacterial challenge is not only associated with oral infection among children, but also predicts increased early childhood caries occurrence. Or in English, what they're saying, if mom has high levels of salivary bacteria, you're going to find it in the kids, and it will lead to an increased incidence of early childhood caries. And so really what you need to look at is how do you control the spreading of it from one to other. Now it comes about because it's not just strep mutans and lactobacillus living on a tooth surface, but they live in a biofilm. And I wish I had more time tonight, but biofilms are really a very well-organized community of bacteria. And you see biofilms in a number of areas in nature. And here in the tooth, both above supragingival and subgingival, there are biofilm communities of bacteria, and they communicate one to the other. The communication we're just beginning to understand tells groups and colonies if, for example, there are more carbs in the area, or if they're not, or if there are other challenges to the ecosystem. And as we begin to understand this more, we can then begin to look at tailoring our treatment to beginning to treat this biofilm and how to remove it. So here we can take briefly, we all know this as dentists, the phases of plaque formation. The first thing that happens as soon as your patient leaves your office after having their recare appointment, a pellicle forms. A pellicle is really a protein-rich layer that forms onto the tooth from the salivary proteins that are free-floating. And they're very interesting because we find that this may have a protective function. I had the pleasure of looking at these many, many years ago as a student, and I found that a number of them were calcium-binding proteins that were found in this pellicle. And within hours, the pellicles also attacked a whole number of bacteria that have begun to form and create this biofilm community. And then you begin, as it begins to mature over the next couple of hours, you get supragingival plaque, and then you'll find out it begins to separate out into supra and subgingival plaque with different communities of bacteria inhabiting in each of the ecosystems. I found this quite interesting. This is work that was published a number of years ago by Marsh, and Marsh says, look, you can find the spirochetes and the porphyrinalis and mutant streptococci and lactobacillus all in saliva, but it depends upon where they live on the tooth surface as to what disease entity you're going to get. And the caries ones tend to live above the gingival crest, and it's in an area where they really do well. They love the sugars, whereas the ones causing periodontal disease live below the gingival crest. And there's mechanisms that allow them to live in these various different ecosystems. Tonight we're focused on caries, but perio disease is also, we know, a bacterial-driven disease, and it's the different groups of bacteria that are involved in driving it too. Again, coming back to the work that Featherstone published in 2000, and he begins to describe caries and no caries as really a balance between pathological and protective factors. And the reason for bringing this up here is that this is the messaging that you give to your patients, is that it's a balance. And it's a balance between the acidogenic bacteria, the reduced salivary flow, the frequency of consuming carbs versus their oral hygiene at home, exposure to fluorides, chlorhexidine, iodine, salivary flow. And it's this balance that determines how the disease will progress, not when you place fillings. Now, Featherstone went back in 2012 and said it's a little bit different looking teeter-totter than just a simple one. And he's now changed it to take a look at the disease indicators, the risk factors, and the protective factors. And the reason that he's done it this way is it then fits into that whole concept of risk factor, risk analysis, and CAMBRA, which we'll talk about in a couple of minutes. So again, you see the protective factors are saliva, sealants, antibacterials, fluorides, and diets. The disease indicators are white spots, the number of restorations that have been placed in the last 3 years, the enamel lesions and cavities that have progressed into dentin. And the risk factors, he has bad bacteria, the absence of saliva, and poor dietary habits. And it's looking at this imbalance that will tell you whether you're driving the disease in one direction or the other. So what about risk assessment? Is risk assessment really a good tool? Well, in my opinion, it's better than what we have at the moment, because we really need to understand who's at risk, and not all of our patients are at risk. And some of our patients may develop risk over time. So, for example, a child who's come through your clinical practice up until age 10 years of age and has absolutely no caries, the fissures look great, and then suddenly they start playing sports and start consuming sport drinks. So now your risk factors have shifted, and caries is going to occur. So the message I'm trying to convey is that risk assessment is good, but it really looks at the historical part to looking at caries. But it's really the best of what we have at the moment. So CAMBRA is really one of the means of looking at it, which is caries management by risk assessment. And here with CAMBRA, when it was developed, you look at both the child and the caregiver in order to develop what the risks are of them developing disease. And you can then begin to customize a treatment plan, which involves both the restorative and the preventive parts to this plan. Not just the drilling and filling, but also what preventive aspects you can introduce, when you should be introducing them, how frequently should they be coming back into your practice, and dealing both with the entire family. Because remember, this is an infectious communicable disease. So what are the risk factors? Well, this is a pretty extensive list, but the one that I always highlight at the top is low socioeconomic status. And I'll share with you a cute story from my clinical practice. I asked my receptionist, who do you think would be at risk for developing caries? And the first thing she said to me, most of your patients, they're on social assistance plans, because I see them being booked back in very frequently for restorative appointments. And I realized, that's right. That's one of the biggest drivers for caries is low socioeconomic. But you add into that as well concentration, the titers of cariogenic bacteria, the number of restorations, eating disorders, alcoholic use, active orthodontic treatment. There's a whole long list. But these are the risk factors. And looking at these risk factors can then help you to identify patients that need to be managed more intensively. And this is a very look at a very quick risk assessment chart that was developed following CAMBRA and used at UCSF. And here we look at it quickly. There are biologic, protective, and clinical findings. And by simply getting, you circling or filling this out or having one of your staff, you can begin to look at introducing a CAMBRA type of management into your practice. And these are available at the California Dental Association website. I encourage you to go there, download this, and very quickly you can begin to do risk assessment in your practice. This is 0 to 5 years of age, and this is over 6. Just simply circling this, putting it into the chart, you've then been able to define whether your patient has these risk factors. And they also produce a very quick self-management goals that you can provide to your patients that are, have very nice little pictorials so they understand how they are to change behavior in order to lower their risk. Now, and the final thing to look at, this looks a little bit daunting, but the American Academy of Pediatric Dentistry has created a risk assessment tool which mirrors all the information that we've talked about up to now and divides it into clinical condition, environmental characteristics, and general health. Again, this is available at the aapd.org website, and I encourage you to look at it, but it's another way of quantifying risk and deciding and defining who is at risk of developing caries. So before I leave this, it's like, well, why talk about this? What's the relevance to it? Well, in the United States, there are now CAMBRA codes that were just introduced into the ADA fee guide this year. And in talking to some of my colleagues in the insurance industry, they're beginning to think about, can we begin to tailor treatment specific to their caries risk? Now, I don't know if I agree with this or not, but I'm letting you know that if this is a trend that the insurers are beginning to look at, it becomes really a trend that we as clinicians should be looking at as well in a much more organized fashion. So just to summarize, my key points are that we've talked about caries as a disease. It treats across a continuum from the earliest part of the disease, which is breakdown subsurface, to full cavitation. It's bacterial driven. There are a number of protective factors that are involved. And again, I apologize, it's at a very high level. We usually, a colleague and I spend about a day going through this, but these are the highlights of it. So, and finally, there are risk assessment tools that you can easily adapt into your practice that will allow you to begin to quantify risk and then guide your patients onward. Now, sometimes patients will have a hard time understanding it or a hard time modifying behaviors, but it's important to start to assess the risk and to record it in your charting. So the next thing is how do you detect it? So we know how to define the risk. We understand what's the pathogenesis of the disease, but now there are a bunch of devices out there that we use to detect it. So let's look at them. So what are the tools for detection? Well, my favorites up until about 14 years ago were visual exam and radiograph, and they're still my favorites today because they allow me to quickly assess with two tools what's going on that tooth surface or at the contact areas if I'm looking at radiographs. And then add to that, we'll talk in a bit more detail, Diagradent, which was the first step towards moving to look at caries and look at something other than visual exam and radiograph. And we give them a lot of credit for introducing this device. Since then, we've had devices such as Caries ID, which has not had good market penetration, QLF, or quantitative laser fluorescence, developed by a dear colleague of mine, and a very good tool for measuring surface changes, Spectra, Sopro, Caries Scan, which unfortunately is no longer on market, and we're the Canary system. So what are these all measuring? Well, first thing we have to take a look at, what are they doing? Well, you have a tooth, and what you need to do is figure out what happens when energy or light interacts with that tooth. So first off, we have reflection. So if we're a dentist and we're using a visual exam, all we're looking at is reflection off that tooth surface. If it's crusty, if it's not crusty, if it's roughened, if it's not roughened. But it doesn't tell you anything about what's going on beneath the surface of the tooth. The next thing you have is scattering. Well, what happens here is that you have light or energy enters a tooth, and as it hits things, it scatters in one direction or not. And sometimes you'll have, we call them photons, which are packets of energy, will backscatter, or sometimes they go all the way through the tooth and come out the other side. If you put a radiographic film on the other side, the scatter becomes part of, if there's something there, or if there's caries, there isn't going to be anything to cause any scattering. So we have reflection, scattering. Then we have transmission, which is very much what you see with fiber optic light transmission. Here, light just shines all the way through. And if it encounters something, you may see a shadow. So that's the third way of looking at how light or energy interacts with the tooth. The fourth is absorption with heat production. So this is a phenomenon that Canary's built upon. We'll talk about that in a couple of minutes. But you have to figure out what's being absorbed, where the heat is going, and what happens once the heat is produced. And finally, you have absorption with fluorescence. And here you have to ask, what's fluorescing? And what are you measuring when it fluoresces? And so if we then say, here are the 5 ways that light or energy interacts with our beloved tooth, we then have to look at how these devices then work. And do they actually allow us to measure and detect caries? So the principles of diagnosis is really to detect the earliest signs of caries demineralization on the enamel and root surface. So looking at those 5 things that we can do with light or energy, we've got to go forward. And if we can find demin, we can find a preventive way for treating caries. So, guilty of watching. I love this slide. I borrowed it from Premier Dental because this is what I used to do. You say to patients, you know, you got a suspicious area there. I'm going to watch it. Well, what the hell does watch mean? It means withhold action until client hurts. And once we're finished tonight, you'll have a better understanding of the fact that there are devices that allow us to measure and to quantifiably monitor, and there are ways of actually remineralizing or hardening that tooth surface. The classical detection tools that we have are Visual, Explorer, and X-ray. And really, the Visual and Explorer are only looking at surface phenomena. And here are the 3 different things that they can find with it. But none of these methods, in my opinion, can really detect the lesion early enough to allow us to implement any type of preventive program. Explorers, I want to emphasize, are really not the best way of looking at pits and fissures. And my colleague Kim Ekstrand, many, many years ago in '87, said, don't do this. Don't take up your Explorer and go poking at a pit or fissure, because all you're going to do is inoculate that pit with bacteria, and you're going to break up the crystal structure surrounding that pit, and thus make it more susceptible to caries. Radiographs are great if you're looking for a lesion that's fairly large halfway through dentin, or halfway through the enamel shell. I apologize for that. But there's work that's been published by Dove and others that says that for early caries, it's very difficult to measure and quantify changes with radiographs. But radiographs also, as part of our normal examinations, provide us with an idea as to what's happening to the supporting alveolar bone, and they allow us to image beneath restoration, such as amalgams and composites, especially on their gingival seats. So they are valid tools, but they are not really, in my opinion, the gold standard. In my opinion, you'll see it's a combination of a number of these technologies that will allow us to get the gold standard and then use our heads to decide the treatment plan and the diagnosis. One of the failings for radiographs is that you have a restoration such as this old amalgam, and I tend to be fairly conservative, and everything appears to be normal, but once it's removed, you can see there's a fair bit of caries in there. But when you're trying to shine x-rays through that tooth, the amalgam may shadow or block the caries that are beneath it, and also it's not going to show you caries along the walls of the restoration. So visual, we use DMFT and DMFS, decayed, missing, and filled, and decayed, missing, filled surfaces. There's also ICDAS I want to show you as well too. So what is DMFT, DMFS? That's what we record in our data charts day in and day out. And it's a good way of telling us what's the disease done till now. But it's only a measure of past experience. ICDAS is a new way of ranking lesions. And I'll show a little bit of this to you and then encourage you to go to their website to learn a little bit more about how this is done. It uses visual exam, but what it allows us to do is to begin to quantify what's doing in this early stages of decay, so we can start thinking about what's this early lesion, only using visual exam, which is a weakness, but at least we're beginning to classify things. So we're already using parts of ICDAS for 4, 5, and 6. Shadow, underlying shadow for lesion, distinct lesion, and very frank cavitation. ICDAS was developed to help us look at opacities which are only seen on a tooth surface when it's dried, and opacities are seen on a tooth surface when it's wet, and some localized enamel breakdown. So if we can begin to score our lesions tomorrow, ask our hygiene team, you know, that buccal surface, there's a white spot there, let's score it as a 1 or a 2, we are now beginning to look at surface changes which may indicate something that's going on beneath there, and saying, instead of saying the buccal surface of that central incisor has a white spot, putting down ICDAS 1 at least tells you the level of where you're at. So again, let's look at, there's 6. This is ICDAS 5, and we're recording this already in our dental charts. We know what to do with this. We know what to do with this too. But where the beauty of ICDAS comes in is in these sorts of here, loss of surface integrity, or where you're looking at loss of opacity when you dry it, that's 2. When it's wet, and then when it's dry is 1s. And these allow you then to record these things. If you want to monitor it, at least you have a numerical grade to it. So that's ICDAS. Now, is it real value to us? It actually is, because ICDAS is being looked at as part of a larger diagnostic classification system that the American Dental Association is looking at. So what are the other detection methods that we have? Well, there are fluorescence-based methods. Diagnostic and Caries ID use a red part of the spectrum. And you then begin to ask, what are they detecting? Remember, fluorescence is glow, and it tends to be a surface phenomena. And with Diagnostic, they've made it clear that what they're detecting is the presence of porphyrins, which are bacterial byproducts produced by a number of bacteria, but not by strep or lactobacillus. And so that what you're detecting is bacteria, but not the bacteria that initiates the disease process. Caries ID by Midwest has a similar type of fluorescence. It doesn't have a numerical scale. It has a go, no-go to it. QLF is also fluorescence. But here what QLF has done, and this is not available in the U.S., it's available in Europe. It was for a bit of time available in the United States. It actually uses a blue-green spectrum to allow it to measure changes on the surface. It's got very fancy, sophisticated technology, and some very good clinical trials that show that it can actually monitor these lesion changes at the surface. It has some limitations that you need to have this done in a darkened room, and it is a bit expensive, but as a fluorescence device, in my opinion, this is the best on market. If we then go to Spectra, Spectra is a softened down version of QLF. And here what they've done is taken a scale of between 0 and 5 and used that to rank out whether there's decay there based upon fluorescence or upon the presence of bacterial porphyrins. My concern is that the scale is very small, and with the standard deviation being 0.25, we may not be getting something that's accurate enough that allows us to build a robust remin, demin, or preventive program. SOPRO is another system that's fluorescence-based, and SOPRO has a couple of, just beginning to publish some data now, no clinical trials as yet, and again, they're looking at, they claim they'd be able to take a look at light that penetrates right through to the DEJ. And green indicates healthy, red indicates infected dentin. And again, you're looking at bacteria, not in terms of actual destruction of tooth structure. You have transillumination, which is diphody, or even if we're using a white light to shine through the tooth, you're looking at shadows where caries has destroyed a piece of tooth. And DEXIS has just introduced Caries View, which they've integrated into their new radiographic system. DEXIS uses a red laser, and they shine light along the gingival crest and then measure the light as it drifts up to the occlusal surface of the tooth and claim that they can then detect caries, specifically interproximal lesions. They also claim around the margins of restorations. There are no clinical studies or trials yet. What's nice about it is that it does integrate with their X-ray system, a radiographic system, but again, we have to take a look at the sensitivity and specificity of this, and if shining light along the gingival crest really gives you the ability to monitor smooth surface lesions, which it doesn't, or detect thick and fissure caries. And then we come to, here's my bias, the Canary system, but this is taken a different way of looking at it. So instead of fluorescence, we're looking at dropping energy into this tooth surface and seeing what happens. So we use a red laser, and we pulse it. And we really don't care what happens when the lights are on. We're more interested in what happens when the lights are shut off. When the laser's shut off, the laser energy wants to escape, as everything physically wants to get back to a lower energy state. And it comes back off that tooth surface in two different formats. It comes off as heat, or photothermal, and luminescence, which is a near-surface phenomena. And what we've done over the last 14 years is measure the interrelationship between the luminescence and the PTR and see how they interact with the status of the crystal structure. We claim that we can see lesions up to 50 microns, as small as 50 microns in size, up to 5 millimeters below the tooth surface, and we haven't increased the surface temperature by less than 1 degree. And patients in clinical practice say they don't feel anything at all. We then take a number of measurements. So we are measuring the infrared, or the heat, the luminescence, or the glow, and we measure 4 pieces of it. We measure the strength of the heat, or the PTR amplitude, the phase, or the shift as that wave comes out, the strength of the glow or luminescence, and its phase shift as well. And during a 5-second scan, there's 750,000 pieces of information that are ticked up off that tooth surface, and then calculated, and up we come with a Canary number, which goes between 0 and 100. And the Canary number then tells you the status of this crystal structure. And depending upon the topography that you're measuring, it will indicate for you what the status of the crystal structure is. So obviously pits and fissures may, a 20 on a pit and a 25 on a pit and fissure may indicate a deeper lesion than a 25 on a smooth surface because of the topography of the surface. So, just to show you a little bit further, there's our plastic tip touches the tooth surface, the laser flips on. The laser diameter at the contact point is about 50 microns. And what happens is it spreads into the tooth, and you can see it's picking up this area of caries here, and it then, the thermal wave goes in, and as it goes in, it radiates out to about 1.5 millimeters in size, up to 5 millimeters in depth. So it looks like a little cone. And anything in the path of that cone is picked up. And when the lights are off, it then is picked back up by the Canary system, and we can then measure the change in the infrared. And the luminescence is the surface phenomena, what's happening on the surface. And it's the interaction of the two of them that gives us the Canary number. So we've been able to produce with 60 articles, over 60 article peer-reviewed publications, Caries detection on pits and fissures, smooth surface interproximal regions around the visible margins of restorations, beneath sealants, including opaque sealants, which we released last year at the IADR, on root surface, and the Canary can detect cracks, which has been a big boon in my practice. Absolutely amazing. It's really helped me out of a number of difficult situations. It also creates a patient report because we wanted to see how we could engage our patients in understanding their risk, in understanding that caries was a disease. And so you can see that there's a report. Everything is colored. And what totally amazes me is when we print this out, patients come back in weeks later and say, are you going to be doing the 70 today? Or we then come back to them and say, you know, we've been looking at this tooth, and it's still at 48. So, Mrs. Smith, why is it not there? And she doesn't turn to us and say, it's not working. The tables are now turned, and we're talking about a quantifiable number. And Mrs. Smith, how do you think we can get that 48 or 47 down to a 40? So now we're using this to change the character of the relationship between us and our patients so that we're using numbers, they can track the numbers, and the numbers are telling them whether their behaviors and their preventive therapies are working. This is a short review of a sensitivity and specificity study that we did with the University of Texas, and we continue to do a number of these studies over the years. It's not just how sensitive it is, but how specific it is in finding disease that's really key. And we tend to rank very, very high in each of these studies, and I think we've done about 5 or 6 of them because it's always nice as we're doing any of our work to see what our sensitivity and specificity is. So let's look at a clinical case. And I was going to share one I saw like 2 days ago, but this is one from just a little while ago. Patient shows up in my clinical practice. They're complaining of pain on a temperature change in the maxillary right posterior area. No tenderness on percussion. There's pain on cold in the buccal surface of that tooth. There's no pain on cold in the occlusal surface. I pick up my tooth sleuth. I load each cusp of this particular tooth. There's no pain at all. And then in my typical old-fashioned head, I'm saying, it's gingival recession that's causing the pain. And part of my head says, you know what, Stephen? Get the Canary. Don't dispense some dentin sensitivity treatment. Get the Canary. See what's going on. So here's some radiographs that we took that day. Things look fine. There's a PA there, nothing really suspicious. And then we took our Canary scan. The Canary scan, what we do is we capture an image in our detailed scan, and then we scan around. We then apply the handpiece in various areas on this grid, and the number is recorded in that grid. And we're getting 44, 43, 36, and all these are indicating that there's something doing around the margins of this restoration. So the occlusal surface is now telling me I think there's something doing. There's the buccal surface. Here's our area of recession. There's nothing. I opened up the tooth. And you can see the caries, a little crack here, and here as well too. So what originally started off as a diagnosis of hypersensitive dentin, exposed dentin on the buccal surface of the tooth, really wasn't that. It was caries. It was caries around the margin of the restoration. And continues to amaze me. This happened on Tuesday morning as well too. So I replaced the composite. I went ahead and scanned the margins again. So compare it before to now. You can see that we've sealed these margins quite nicely. My Canary numbers are low. We followed up with the patient in 3 weeks, and I've seen her over the last 6 months. Everything is fine. So what we were able to do was to prevent this patient or avoid possible endodontic therapy, fracture of a cusp, and my diagnosis was wrong. It wasn't dentin hypersensitivity. It was caries. So my ROI, which I really feel uncomfortable about, is had I just gone ahead and just done the simple thing, it was $90. And here, having gone ahead and placed the 3-surface composite, it's $270. But what's most important, it was the right diagnosis. The patient was most appreciative. This is an example of a patient who came in with orthodontic brackets, and we scanned around the brackets. and the oral hygiene wasn't great, we said to the orthodontist, will you please debond these? Look at the brown stains along here. And the 47s and 45s are telling us that we're caries there. Pitt and Fisher caries, another example of a patient low risk, high number. Couldn't believe it, opened up caries. Interproximal caries lesion, again, on this maxillary left first molar. I scanned on the occlusal, and both interproximal here was a 40. I couldn't believe it, opened up, and there was caries just underneath the buccal cusp. So there's also studies that we've done which looked at detection of caries under sealants. So when you place the sealants over a caries lesion scanned, again, this is work that we produced last year, we were able to find caries 83% of the time. And our suggestion is if you have a canary number over 20, when you're scanning on sealants, open it up, there's caries beneath it. So what are people saying about it? And Ben Amici, who's been working with us for many years at the University of Texas at San Antonio, describes it as an excellent device for caries detection. Larry Emmett, one of the editors at Dental Compare, he describes it if Dennis, this would have been a tricorder if, it's very, very accurate for Dr. McCoy. Todd Snyder says he finds this technology extremely accurate. And these are a couple of new users of ours who talk about what it can do and what it's been doing for their practice. It's allowing them to track caries around the margins of restorations, and they find it accurate, easy for their patients, for their hygienists to use. 3M has been saying it's a good way for them to monitor their remineralization program. And so looking at a comparison between the Canary, Diagnodent, Spectra, and Sopro, you can see, again, with my own bias, but with what I've told you, the Canary really has the ability to track changes in the crystal structure of the tooth and not measure the presence of bacteria. So now, having looked at devices and realizing that you can run a preventive program with iCDAS, at least as a start, and Cambra, or the other devices out there, Spectra, Sopro, the Canary system, how do you build a remin program? Look at all these therapies. Which one is the best? Is it the GC's MI Paste, 3M Vanish Varnish, the Sensodyne Repair and Protect? And I'm going to tell you that they're all really excellent. But you need to find the right combination that works in your patient's ecosystem or your patient's mouth. And finding the right combination means having the devices, looking at the risk, and seeing your patients on a regular basis. We look at remineralization as if one goes to a nice buffet, and you pick from the appetizers and the main course, or the office and the home therapy. And in the office, you have topical fluoride gels, which are okay, fluoride varnish, which is very effective in a high-risk population, antimicrobial therapies, oral hygiene, diet counseling. And on the main course, in the home therapy section, you've got Clinpro, Proarginine, MI Paste, the Novamin, are all very good paste to be using on a daily basis. Sugar substitutes such as xylitol, Paradex and triclosan products, Recaldent and xylitol. I'm sure I've missed some of them, but what I always say is the best way is looking at office plus home with effective plaque removal, brushing, and flossing. So the essential components for a remin program are you need to have monitor and record, change therapy if it isn't working, engage your patient. So, Mrs. Smith, we seem to have these white spots are still white spots. They don't seem as hard. Or my caries detection device is showing that the numbers are getting worse. Let's change off this toothpaste. How frequently are you using it? So it's not just a simple cookie-cutter solution. Fluoride is great. We all know about fluoride. It enhances remineralization. It inhibits D-min, and it inhibits bacterial activity. So I just put that up there just to emphasize to you that it's a really good foundation. And in my opinion, a good foundation to start your remin process. But there are others that can become part of your office or home therapy. 3M Vanish with TCP is a really good type of fluoride varnish to use. We've used it in one of our clinical trials. And this one's sweetened with xylitol. It delivers 22,600 parts per million for a high-risk patient. And we found over time that we really got very nice results with a combination of 3M Vanish, and this is how it works. It's depositing on that tooth surface calcium, phosphate, and fluoride, the essential building blocks to remineralize an early lesion. We combine that with 3M's ClinPro 5000 toothpaste, which also has calcium and phosphate and fluoride, packaged up so that they don't clump or crystallize inside the tooth, inside the tube, and you get a very good type of high concentration of the building blocks once it's dispensed and brushed on the tooth surface. This is from one of our clinical trials where we looked at it, and over a 5-month period, we always had this brown spot, but we found our canary number drifted slowly downward, indicating that as we measured this spot, that it was remineralizing below the surface. And we validated this looking at a number of in vitro as well, too. This is a more real-world type of experience. This is one of my patients who we've had on a Remin program now for a little over 2 years. Initially, this is on a lower molar, and you can see what the lesion looked like, and here it is 25 months later. You can say, geez, it still looks, but what we've been able to do is to measure every three months. She's in for Vanish fluoride varnish. She's using ClinPro 5000, and we've taken the canary number and slowly had it drive downward to now it's down below 40. Now, should we have treated it at 70 where it was? Yeah, we should have, but I decided that since it was a low-risk patient, and this was an area that she needed to be encouraged to clean, but she could clean and keep the plaque down, that it was worth taking the risk, and I would be able to watch and monitor it. And it's doing fine. The question you may have is, when will this stop? And what we're going to do in the next, at the next recall is to move out to 6 months and then move out to 9 months, always looking to go back and remeasure with our canary system. So how do you integrate remineralization therapy into your practice? Well, you look at this circle of contact every 3 months during the process. Why? Because the literature is telling us that if you're using fluoride varnish as a start, this is optimal time for dosing your patients. If you're using another type of home or office-based Remin therapy, take a look as well, too. The literature tells us that typically it may take 3 to 4 months before you can begin to measure changes in that tooth surface, depending upon which technology that you're using. And so we're having 4 touch points during the year with our patients. And the touch points only take 15 minutes of time, except during the recare appointment when we're doing a number of other procedures as well, too. So how do you integrate this into your practice? Well, first off, integrating a canary into your practice, you can integrate it, as we say, as part of your recall. What you would do if you're using a canary is you scan just a few surfaces using our quick scan, include the fees in your recall exam, and the message to your patients, a new way of providing detecting tooth decay for your practice. You can look at it in some of our practices when they're looking at the canary system, are actually booking patients in for a complete examination. And what they do at that point in time is say to the patient, I've noticed a couple of suspect areas, and I'd like you to come back for a complete examination. And they use the specific examination codes that are available in both the ADA and the Canadian fee guides, and they book 45 minutes. And there what they're looking for is lesions that can be remineralized and also lesions around the margins of restorations. Or you can look at a remineralization program, which I just discussed before. And here, what you're doing is booking 15-minute time increments. We use a detailed scan, the remineralization code, and the message is that we're seeing you every quarter or every 3 months in order to monitor changes. So that's how we would look at using Canary, or you could look at other devices for a Remin program, but here are the 3 ways. So the billing codes. So what billing codes can you use for running a preventive program? Well, in Canada and the United States, there's a limited examination, or the specific examination is available in Canada and the U.S. The application of fluoride varnish codes exist in Canada and the U.S. Oral hygiene instructions as well, too. CAMBRA, as I told you, was just introduced in the United States, and it is just this year, from my, as I said, my discussions with the insurers is that they are not adopting it yet, but they're sitting back and looking at, can we develop a risk-based preventive program where you provide us with the CAMBRA code, and then we decide upon how many services the patient accesses. The other places for billing codes are nutritional counseling, treating dentin hypersensitivity, and the U.S. fee guides is application of desensitizing resins, and there are a number of other things that you can use. Some of our users are telling us that if they have an intraoral camera, they're also billing for that, and if they're using Canary, they use the intraoral camera and bill them that way as well too. So again, there are ways of billing for it. There is value in building your remineralization program, and patients appreciate it. With the Canary, what we're suggesting is that it can be done by your hygiene or your dental assistants in most states in the United States except for Ohio. You can have your staff apply the Remin therapy. You just show up to confirm the diagnosis and check the numbers. And it's a great way of getting your patients involved in building a remineralization program. Remin is good. Prevention is good. Unfortunately, it tends to be undervalued in the fee guides in Canada and the United States, but our patients value it a lot. So remember that there's a paradigm shift. We can pick up our drill, fill a hole, and say we treated the disease. And we really haven't. All we've done is we've treated the after effects of that disease. Or we can find devices that can monitor and detect these diseases, build a preventive and treatment program and restorative program around what these devices are telling us. The devices can be visual exam, radiographs, Canary, they can be Spectra, Sopro, depending upon what you want to achieve and understanding what these devices are doing. But it's not picking up a drill anymore. I think, and I feel strongly, our patients expect us to be much more preventively oriented. And coming to the end of it is that you notice I've been focused a lot on caries detection because it becomes really the anchor point or the platform for any preventive program. You really need to find the ideal caries detection system. Again, I have a bias, but looking at my shopping list here, these are questions I would encourage you to ask anybody before purchasing or getting involved with a caries detection system that becomes the platform for your preventive therapy. The first question is, what's its sensitivity and specificity? Not just how sensitive it is, but how many times does it find it right? And those are the two metrics. The second is can it monitor demin and remin? Finding disease is one thing, but if you're going to run a preventive program, if it can't monitor the remineralization, then it doesn't help you to see if you're getting the right outcomes. Can it find caries on all surfaces? That's a challenge for a lot of devices. Can it find caries around restoration margins? Is it non-invasive and safe? Is exposure to it going to cause harm to your patients? Are the measurements repeatable? Do they have experiments that show that repeatability? Is there imaging? I find imaging is a great way of communicating to patients. Giving them a number without showing them a surface really is difficult. As soon as you've got a surface and a number, they're really engaged. How do you record and store those measurements? Because we want to be able to go back afterwards. Or the third-party carriers may someday want to see what we're doing, or your licensing body, or mine. Do they have a system for motivating and educating your patient so that your patient is now engaged in managing this disease? And then I get into evidence-based, in vitro and in vivo publications. But this is really important because making a claim that isn't backed by good, solid evidence isn't worth making the claim at all. And that's one of the things that I've learned in the years of working in this area, is that you need to have very good evidence-based. Show me the data. Show me a clinical trial. And then finally, on my wish list, which is really difficult, is the ability to detect and monitor erosion lesions, because this, I find, is something that's on the rise in our clinical practice here in Canada and Toronto, and we're also seeing this as I talk to colleagues in North America too. And finally, the key is you have to understand, what is this device measuring? What are you measuring? Are you measuring bacteria? Are you measuring glow? Are you measuring what? Tell me what you're measuring. If you have all these characteristics, then I understand how to integrate you into my preventive program. Again, I want to thank you very much for spending the time to listen this evening. And I know that Danny will be able to take questions in just a minute or two.
I have been doing so throughout your presentation, Stephen, and well, we got a lot of them, but that was great. Let's dive into that. Actually, on the screen now, I actually want to make sure people who are maybe not watching are hearing, and we get this on the recording. The QDT is actually offering a risk-free trial for the system. Do you want to just speak a moment about that before we get to the questions?
Sure. If you're interested, and I would encourage you to, we're offering a risk-free trial for all participants on the webinar this evening, and the offer ends April 30th. The phone number is at the bottom of the page. It's 866-993-9910. Press 3, or sales@thecanarysystem.com, and speak with one of our staff, and they can arrange for a 30-day risk-free trial where we will get your device into your office, provide you with the training, and get you going on using this particular caries detection device to provide you with a platform for the traditional drill and fill, but also a platform for building in what is, in my opinion, a very robust preventive program.
Well, that's great. I appreciate that. I know we had talked a little bit about that, and I really appreciate you extending that offer. It sounds really like no lose. The one thing that occurred to me, and Mary actually asked this as well, which is maybe she anticipated this, but you know, what looks like a sophisticated piece of technology, one might say, well, am I really going to be able to do what I need to do in terms of learning and practicing and vetting this system and seeing if it works for me within that 30-day period? In other words, what kind of a learning curve are we looking at, Stephen?
The learning curve is very, very easy. It's a point and scan. And so the learning curve is basically, how do you put it into your practice? Who's going to be your practice champion? And what we do in terms of training is we're using a virtual method of training, which is actually quite niche because there are a number of touch points that you would have with our clinical team. There are a series of 14 videos that will show you how to unpack it, and and how to set it up, how to do the scanning. And in addition to that, our clinical team will call and walk you through either by Skype or on the phone on how to use it. But literally, it's pick up, apply it on a tooth surface, hold steady for 5 seconds, you get a number. And that's as easy as it gets. The key thing you have to wrap your head around is, when am I going to use it, how am I going to use it, and who's going to use it? And those are the things that we'll train you on.
That sounds really simple. You mentioned in your presentation you were going to be talking to the government on Friday. I'm just curious, what's that about?
Well, here in Ontario, that's one of my volunteer jobs, is to talk to Ministry of Health about their children's programs, and they're now looking to integrate a number of programs into one. And our message to government is you know, it's time to move away from the drill, fill, and bill approach. We want more prevention. We want to engage our public health community in reaching out to low-income Ontarians and getting them into the dentist. And we want to establish a dental home within a dental office. We don't want to see, in some of the areas in Ontario, they're driving around on a bus and treating caries. And caries is not treated on a bus. It's treated in a dental practice, and it's not an episodic event. It's a disease that needs to be treated over the lifetime of the patient. And those are some of the messages that we'll be delivering to government on Friday.
Well, that's great. I appreciate it. I know that your fellow Canadians appreciate it too, and I'm hoping to see movement in that direction in our country. It's really in everybody's interest because we're talking about prevention. Prevention saves pain, lives, and money. Should lower insurance premiums. And fortunately, I think we are seeing more movement in that direction on the part of the insurance companies, the third-party payers, that they see it's in their own interest to encourage prevention and treatment. Makes sense and saves dollars. So that's great.
Well, the other thing to realize is that it's not going to put us out of business, because even in the populations in a fluoridated community, our under 30s, there are still a number of things going on that need to be watched, monitored, and treated. the use of sports drinks, the use of pop, the steady snacking, all increase the risk of developing caries, specifically in pits and fissures. A lot of kids have had orthodontic treatment done, and they've developed some white spots that haven't resolved. Remember, a white spot is not just a white spot, but it's an indication of some subsurface breakdown. And these are techniques that we should be able to treat, not just with the drill and fill approach, but in building a very robust preventive practice.
Mm-hmm. You mentioned at a certain point in your presentation that I think x-rays and visual exams are still your favorite approach. This is obviously, it gives us a far greater insight into what's going on under the surface far more effectively than radiographs can. But is there any value any longer? Where do you see what's the future of the x-ray, in your opinion, Stephen?
The x-ray has still got a place in clinical practice, because remember, the x-ray provides you with a picture. A bite wing radiograph, for example, provides you with a picture of the supporting alveolar bone. It provides you with a view of the gingival seat of that particular restoration. And those are areas that the other caries detection devices really have trouble, especially if you've got a subgingival restoration where you've got gingival tissue in front of it. It's very hard at this point in time to shine something through gingiva and then pick up that restoration margin. And so a radiograph is good there as well, too. Radiographs at contact points, one could argue that some of the technologies, in particular ours, may be a good way, a nice adjunct of working together with radiographs. There was just some data we presented at the AADR meeting in Charlotte 2 weeks ago where we compared radiographs in vitro to the Canary system, and for early lesions we were much more accurate. There is an in vivo study being done, which should be reported out sometime this year. My understanding is that it's mirroring what we're seeing in vitro. So it's complementary. I'm not saying we should get rid of them, but it's a very complementary technology. It can be used more frequently than x-rays, and it can be used to measure changes in the crystal structure of the tooth.
Mm-hmm. Absolutely. You pretty much covered this, I think, in one of your last slides. This came in earlier, but it might bear a quick review. What are the critical factors in selecting a caries detection system?
Well, let me go back for a second. These are the critical factors here, and I want to emphasize that I think, number one, I know it sounds really sciencey, high sensitivity and specificity. And I think if you ask for both of those, that's really, really critical. Sensitivity means your ability to detect disease. Specificity is the ability to detect the absence of disease. And you need both numbers. So I know it sounds really sciencey and statistical, but it's a good measure. It's something you should be asking for. And then again, looking at data, looking at the evidence that they're presenting you, not just a claim, but do you have good evidence? And I know that it sounds like it's ponderous and difficult to do, but for example, I just installed digital radiography a little while ago in my clinical practice, and I spent a long time talking to people about sensors and sensor technology, and I'm very pleased with what we ended up purchasing because it's delivering, because we asked the right questions. And to me, these are the right questions for a caries detection device.
I'm actually thinking about, we hosted Julian Holmes several months ago, and he spoke about ozone therapy, and there was a study using a device that you're mentioning, but I won't mention which one it is, and they used it to try to measure the reduction in decay through the ozone therapy, and it was indicating no reduction, and it turned out that the sensitivity wasn't sufficient, that they were already, well, actually that they were off the chart on the other side, that they were reducing it, but that they weren't measuring it sufficiently where it really was because the degree of decay was already off the charts. And so I guess you got to be aware of the sensitivity at both ends, although it may not be as pertinent when we're talking about.
It's actually, it brings up a really good fact. And this may not be for a discussion tonight, but I think that we as clinicians need to ask a lot more questions of our research community about how they validate, how they assess, and how they design studies, because I've seen studies in our area where they were looking to validate, you know, 2 devices and visual exam was the gold standard. And I'm thinking, you got 2 devices and you're saying your eyes are the gold standard to say whether there's caries there or not? It's like, no. You have to find a way of actually sectioning, removing, whatever, but saying, oh, because I can't see it, there's no disease there, that doesn't make sense.
Mm-hmm. Another question came in, does remineralization therapy really work? And I suppose that depends on which therapy we're talking about. But I'll let you answer.
Well, that's a very good question. And the answer is, yes, it does. It has a number of challenges to it, but it does work. Remineralization therapy can be as easy as having your patients brush their teeth each night. That's remineralization therapy at its easiest. What we talked about here is some data that we shared from a clinical trial that ran 9 months, and then from things that we're seeing in our patients population. And in our patient populations, patients being compliant, coming to their 3-month appointments for 15 minutes and using their paste at night or whatever we're using, yes, it does work. We have a clinical practice in London, Ontario that runs what they call a Canary Day. And they're using the Canary as their diagnostic platform, and they use a variety of different remineralization therapies for their patients. They say to their patients, if you want us to treat it, the cost is X dollars per year. It gives you 4 visits and some of the tools that you need to get started. And they've gotten very, very good results. They said the lesions have stayed static, or they haven't grown in size. The Canary numbers have stayed stable. They have no cavitation, and the patients have been compliant. So it does work, but it depends upon patient compliance, understanding the ecosystem, having the right diagnostics, and engaging your patients.
Terrific. We've still got time for a couple more questions. Let's see. Let me select here. Well, what do insurance companies think about these new preventive therapies?
It depends upon whom you speak to. They're interested. They want to see more studies because obviously they're looking at, can you lower my costs? And so from the discussions that I've had with some of the third-party carriers and their science staff is that this is the way to go. We need to see more studies, and we are interested in paying for it if it can reduce our back-end costs, especially if it reduces our back-end costs substantially. Governments, I can talk about here in Ontario, and looking at the literature in the United States, they're already partway down the road in terms of preventive therapies. You see a lot of talk about fluoride varnishes and their value in stabilizing or being used in a high-risk population. And in Ontario, for example, we have government convinced in one of our programs to actually cover not just fluoride varnish, but any of the remineralization therapies so that we have a generic code that's used. It's not dosed properly, but at least the code is there. So I see this as starting. One of the other things that's been going on internationally is an initiative being driven by Professor Amit Ismail at Temple University in conjunction with Dr. Nigel Pitts at the University College in London, England, and they're looking at the global management of caries. And they're looking at both the diagnostic codes, the diagnostic devices that are there, and the therapies that can be used. So that's another initiative, and they've engaged the insurance companies, and they've engaged government and the ADA as well. And then you have initiatives such as what the groups have been doing out on the West Coast with CAMRA and its messaging as well too, and the California Dental Association, and there are other professional associations throughout the United States that are messaging too. So does it work? Are insurers interested? There's a lot more buzz now than there was 5 years ago, and I haven't seen, the buzz decrease. I see it increasing year by year. And putting CAMRA codes into the ADA fee guide, I think, is a very big step in terms of getting insurers to think about prevention and risk. So it's on its way.
Yeah, I know you've been talking to Dr. Charles Blair about that, who's very good with dental coding, and I've been speaking with him as well, and I plan to reach out to my fellow AOSH members and other professionals out there to kind of get the data and submit codes, because any code can be submitted. Obviously, the better organized, the more evidence you've got behind the advisability and value, efficacy of the code of the treatment, the more likely it gets accepted. And yeah, that just helps lead to eventual reimbursement is the hope and the expectation. So it's exciting.
It's not just the insurer. If you turn to your patients, now in my clinical practice, and my patients say, I'm not interested. Okay, fine, you're not interested. But in our clinical practice, in some of the other clinical practices, they say, sure, whether it's insured or not, if you're telling me there's a darn good chance if I follow the rules, if I'm involved, if I'm compliant, that these lesions won't get better, I'm in. So to heck with whether my insurer says it's good or not. I don't want to have another filling.
Yeah, well, I'm glad that you make that point, because I'm the last person that suggests that treatment should be driven by insurance companies or by what's reimbursed. The reality is that if anything that can be done to make the decision easier on the part of the patient, and affordability or partial coverage is certainly one of those, then I think there's a no-lose there. I, again, in no way suggest that our treatment should be driven by reimbursement considerations alone, but affordability is important. I'm glad though that you mentioned it. Yeah, I mean, I know we agree on this subject.
Yep. But it's a start. It's definitely a start. I mean, if you go back 10 years ago, 5 years ago, this wasn't even a blip on the radar screen.
Exactly. That's right. So this next question sort of follows from that one, Stephen, which is how do we bill and maximize the likelihood of reimbursement for using these new diagnostic devices?
Let me go back here to, well, here's a set of billing codes that you can use for these diagnostic devices. Let's look at the U.S. column here. So in the U.S. column, you have limited examination and specific examination. So if you're booking your patient in for a session where you're using a diagnostic device, Canary, whatever, and you're examining a number of surfaces, it's a specific examination, and it falls within the definitions of that. The same thing for a limited as well, too. If you're using Cambra, and one of the tools that you're using in Cambra is your diagnostic device to look at lesion evolution, thus increased risk, it can become part of that. If you're using intraoral photographs as part of your diagnostic device, it can be part of that as well, too. So those are just a couple of the codes in the REMIN program that can be used. If your device produces, for example, a report, you could also say that it's part of an oral hygiene instruction as well, too. So in this preventive program, you would be applying fluoride varnish, providing oral hygiene instruction, one of these specific examination codes, and a possible nutritional counseling of what's going on, and then your patient's on the way. In addition, you may be treating dentin hypersensitivity with using these two codes. So there are a number of codes to look at in terms of their utilization for using a caries detection device in a preventive program. If you're using the caries detection device as part of just an examination, then it's these two codes. And as an aside, if it's used to find caries that would otherwise not be found with other diagnostic devices, one of our, using Canary, one of our sites told us that in the course of 8 days, seeing 2 patients a day as part of their hygiene program and doing some Canary scanning with them, they were able to find somewhere in the order of about $4,200 worth of restorative work that needed to be done, wasn't found using x-rays and visual exam, and so that there was an increase in their return on investment, increase in the quality of care that they provided, and they were quite pleased with that.
I can imagine they were. I wouldn't see why not. We've got time for just one more question, and you talked about this a little bit, of course, as well, and I think this is one of the strengths of the system, because even though it's so sophisticated, it's so simple to understand and to Sure, but how do we engage our patients to comply with and follow our treatment plan?
That is the most difficult part of anything that we as clinicians do. And so engagement needs to involve buy-in. So to buy in, showing them a radiograph is very difficult. Patients just don't understand what they're looking at, especially if it's an interproximal lesion. If it's a smooth surface lesion, a brown spot, a white spot, all they're going to see over the course of that remin program is a brown spot or a white spot. As soon as you assign a number and then begin to produce reports, in my opinion, this is a great way to go. And I'll share with you a very quick story. During our clinical trial, we were measuring, and the canary had a voice. And we didn't tell the patients what it was because we were testing it. It was clinical trial. And I went out to an investor meeting a couple weeks after, and the investor said, oh, I had a canary scan. I said, oh, great, what do you think? He said, well, I have a couple teeth with the number 70. I said, oh, my God, this guy's had a canary scan. He remembers his numbers, and he's now telling me that this is what I'm going to have to do. So I realized that part of the engagement needs to be, can I quantify it? Do I understand what the numbers mean? And then can I watch my numbers shift and change? So it's engagement in a measurable way, and then watching the numbers or the measure change to a positive or negative that provides the patient with the inducement to move forward with their change in behavior or preventive therapy. And that, to me, is the way to engage them. How do you measure it? And are you going in the right direction?
Yes, and it motivates them tremendously. Well, I want to thank you, Stephen, for a really terrific presentation. I know our attendees appreciated, as did I, the detail, but equally important, the actionable nature of these recommendations, and most important, perhaps, how such a sophisticated technology presents results and monitors progress, or in other words, if we've just been discussing, how it empowers the patient to take a stand for their own care. I also want to thank QDT for the great opportunity for attendees to sample the Canary system without risk and to have it long enough to prove it for themselves. Remember to watch your email, dear attendees, for details to apply for your CE credit. And please mark your calendars for Wednesday, May 14th at 6 p.m. Central Time, 1 hour earlier than today, when our special guest presenter will be Tony Siegrist Adams, who will share important considerations related to improving dental and overall health literacy and its promise to catapult practice growth and the oral and overall health of your community. Basically, Tony's going to share the keys to, as Stephen just shared earlier, gaining buy-in from your patients, which is what it ultimately is all about. In the meantime, this is Danny Bobrow, thanking and acknowledging you for your commitment to practice perfection. Goodbye, everybody.